Recording started.
Ladies and gentlemen, welcome to the Care Transitions to and from the Hospital for Individuals with Alzheimer's Disease and Related Dementias webinar. This conference is being recorded. My name is Jessie Michalak, and I'm a consultant with the Lewin Group. This is the third webinar in the 2016 series, Geriatric Competent Care, Caring for Individuals with Alzheimer's Disease and Related Dementias. Today's webinar is titled Care Transitions to and from the Hospital for Individuals with Alzheimer's Disease and Related Dementias. This series is being presented in conjunction with Community Catalyst and the Lewin Group and supported through the Medicare-Medicaid Coordination Office at the Centers for Medicare and Medicaid Services. Continuing medical education and continuing education credit is available for today's webinar from the American Geriatric Society and the National Association of Social Workers. In order to receive credit, please complete the pre-test located on the right-hand side of your screen by 12:20 p.m. Eastern Time. Participate in today's webinar, complete the post-test with a score of at least 80%, and complete the program evaluation form. CME and CE certificates will be emailed approximately 4 to 8 weeks after this event. MMCO is developing technical assistance and actionable item tools based on successful innovations and care models, such as this webinar series. To learn more about current efforts and resources, please visit our website, www.resourcesforintegratedcare.com, for more details. All the Q&As and the slides from today's presentation and a recording will be posted on that website. Please contact rick@lewin.com, that's RIC@lewin.com, if you have any questions or additional comments. Before we get started, I'd like to remind you that all microphones will be muted throughout the presentation, but there will be a brief question and answer opportunity at the end of the presentation. If you do have a question, please use the Q&A feature on the WebEx to submit a question at any time during today's event. At this time, I'd like to introduce our moderator. Carol Reagan is a senior advisor with Community Catalyst with over 30 years of experience with national and state-based public policy and advocacy organizations. Carol's work has included policy research, analysis, and legislative advocacy, primarily focused on health insurance coverage, programs and services for low-income children and families, long-term care, and workforce development. Carol?
Thanks, Jessie, and thanks to the Lewin Group for hosting these webinars with us. So welcome on behalf of Community Catalyst and our Center for Consumer Engagement and Health Innovation. We're really pleased to moderate this session today. For those of you who don't know, Community Catalyst is a national consumer health advocacy organization whose mission is to organize and sustain a powerful consumer voice to ensure that all individuals and communities can influence their local, state, and national decisions that affect their health. And a lot of the work at our center is focused on the care of vulnerable populations around delivery system change, and our focus on care for older adults is a major part of our work, thus our commitment to these webinars. So in partnership with the Lewin Group and the American Geriatric Society, we've been hosting this Geriatric Competent Care series for the past few years. This year's focus has been on dementia care, given the importance of helping providers and health plan staff and other team members on how to address a condition that impacts millions of consumers and their families. It's our pleasure to introduce these series and to welcome an incredible group of faculty with very deep experience in care transitions and Alzheimer's. I'm going to introduce the three, and then they will introduce one another at their share. So Dr. Catherine Argawal is a physician in the section of geriatrics at Baylor College of Medicine. Dr. Alan Stevens is a PhD at the Center for Applied Health Research at Baylor Scott and White in Texas. And Dr. Karen Rose, who's a PhD and RN at the School of Nursing and University of Virginia. Today, Dr. Agarwal is running a little bit late, so Dr. Stevens is going to open up those slides and start her presentation, and she'll be able to join us in a few minutes. So thanks so much for joining today, and Dr. Stevens?
Thank you, and I'm happy to be able to represent Dr. Agarwal today, but it is unfortunately my pleasure, but I will not do as good a job as she would have done in this presentation, but she'll be joining us shortly. The presentation as a whole is going to be focused on the impact of hospitalizations on older adults, particularly those older adults with dementia and delirium. So by the end of the presentation, the learner will be able to state common hazards for older or elderly individuals in the hospital, know more about programs that help individuals avoid hospitalization, since we know that many of the things that the negative consequences that occur in hospitals are often unavoidable. So avoiding the whole hospitalization itself is often can be the best thing for the patient. Be able to talk, describe and understand 3 models of care that are beneficial to individuals with dementia while they're in the hospital, and to be able to state 3 quality issues that really speak to high-quality, person-centered hospital care for dementia patients. Next. We all know very well the challenges that individuals with dementia face on a daily basis. As their capacity declines, the world just seems to get bigger and bigger and more difficult for the patient and often for the family to maneuver. And a hospitalization is very often a very pivotal point in the trajectory of the dementia or Alzheimer's disease for the person who is being affected and for the family caregiver and for the family caregiving system. Many caregivers and families tell us, you know, things were going along pretty well until, and the until is very often a hospitalization. Why is that true? We know that dementia patients do best, or persons with dementia do best in a very structured environment and a very structured routine schedule. And going into the hospital throws them into a completely new set of experiences. One, it's a change. Everything looks different. They are more subject to have high levels of anxiety and tension because they don't know where things are. That leads to often more question asking or the need for reassurance, which increases the demand on family caregivers, and it also in the hospital increases the demand on professional care. On the hospital side, and I come from my integrated health care environment, and my office is in a hospital, so I see hospital patients every day, not clinically, but just in my interactions in the hospital. And we know that hospital care is very regulated, it's very regimented in terms of workflows and who's doing what and when certain tasks have to be done. And unfortunately, that creates a sense of, or an environment of dependency in which patients are literally taken care of. They're taken from place to place to meet the demands of the various care that is being delivered. So it's everything from the diagnostic tests that need to be done to medication that needs to be delivered or therapies that need to be conducted. So this creates a level of dependency in which the patients often feel that they're just there and are taken from place to place when somebody deems it so. And this increases the level of I should say decreases the level of walking and increases the level of sitting and lacking of mobility. And that is where we often see declines in the person's functional ability related to motor movement, related to range of motion, the types of activities that older adults will experience a decline very quickly if they become immobile or if they have a strong, significant decline in their mobility. Now, again, some of these things, or all of these things, I will say, again, I'm coming from a hospital, are not intentional outcomes of the hospital. They're unfortunately unintended effects of regulations, of the need to provide care, and in many cases, especially with dementia patients, the fear of a patient falling and hurting themselves. What else happens in the hospital? You have, and I've touched upon many of these things already, you add in the diagnostic tests and the treatments. New medications are often started. Old medications are discontinued. Patients and families often forget about a medication they were taking at home and it doesn't get put on the list, so sometimes medications are inadvertently stopped. Changes in medications are a big one. Bed rest and immobility, we've kind of talked about already. They come from a number of medical issues, or medical delivery, nursing issues, other types of therapies. Because related to the first item, we have change in pharmacy, that we also there's an increased risk of delirium, which often relates to further restriction of the patient's mobility as the risk for falls increases. Restraints are always a tricky topic to talk about, so we won't get into many of the issues of that, but just these, as you see, the sheer physical objects that reduce a person's ability to move freely in their environment. And of course, everyone likes to complain about hospital food. So people often don't find it to be as tasty as the meals they had at home, or not part of their normal routine diet. We try to be culturally sensitive to individuals, but often that doesn't really translate into the same kind of meals that people had at home. Therefore, they often eat less, and importantly, they drink less. So we have to really watch for hydration issues, which we know can, of course, reduce motor mobility and range of motion. And lastly, lack of stimulation. For those of you who have worked in hospitals, you know the amount of time that nurses spend looking for glasses and dentures and hearing aids, especially true at nursing homes, of course, too. So oftentimes things get misplaced, and again, it is all of these things sum up to the person's day-to-day life, hour-to-hour living is now very different than it was before they came into the hospital. And you and I can say, oh, well, sure, you should expect that. For a person who has all of their abilities, it's manageable. But if you're but as a person with dementia, as you are already needing structured environments and routine, the lack of routine interacts with the cognitive declines to make all of these negative consequences worse. Next slide. Excuse me. During a hospitalization for a person of any age, but particularly older adults and older adults who have a cognitive decline, the onset of delirium is a reason for concern and will activate a care team very quickly, because with the delirium comes a number of other negative events of the hospitalization, including patients' families being very upset by this dramatic change and not understanding totally what's going on, and often being, and rightfully so, being very upset by this dramatic change that they see in a loved one. When you add on the risk for someone who has Alzheimer's disease, the risk of negative outcomes increases dramatically. We see that with more cognitive decline. We see it with a higher rate of institutionalization, meaning the person prior to going into the hospital was residing in a family home and are now having to be moved into a more formalized care, such as a nursing home, and they're at an increased risk of death. Cognitive impairment is also a risk factor, in fact, the greatest risk factor for a longer length of stay in the hospital than would otherwise been expected if the person did not have cognitive impairment. So, these presentations are often hard to make because you're just like, all of these negative things that we've been talking about, which are very common, unfortunately, they then go on longer and longer. So for a person without cognitive decline or impairment, the hospital stays are shorter. Yes, they're uncomfortable. Yes, there's some deconditioning. But in dementia patients, you see a worsening across the board, made even more complicated by a greater length of stay. As you can see, 10.4 days for length of stay for a person with Alzheimer's disease, and 6.5 days of stay for a person without a diagnosis of Alzheimer's disease, and this is at a very large sample size. As probably most of you know, the length of stay is a big deal to hospitals. It's related to the cost of the care that's being provided. The hospitals spend a lot of effort, including personnel, on monitoring the amount of care that the person is receiving and when someone can be discharged. So this is not by accident that this happens. It's a clear indication that even when you have very good hospitals monitoring the length of stay very, very carefully, and it being most of the time in the hospital's advantage to make the length of stay the appropriate amount of care length, not a day longer, you still see with Alzheimer's patients an additional 4 days, which is quite dramatic. Next slide.
Hi, Alan. Do you want me to take over?
I would very much like you to take over. And and I don't know how long you've been on, but please go back and correct anything I've said incorrectly.
No, definitely. You've done wonderfully. Thank you, Alan. This is Catherine Agarwal, and I really appreciate Alan helping me out and doing actually a much better introduction to all of this than I would have done. So to keep going, the one thing that's important for everyone to know is that we don't document issues of cognitive impairment well at all in the medical record. And so, unfortunately, that can make it very difficult for other providers and case managers and people that are trying to help with transitions of care, because it's been clearly shown in multiple studies that we don't document both the issue of dementia, that someone has chronic cognitive impairment, and we also fail to recognize more acute confusional states like delirium. So that makes it difficult because those things aren't documented well. Next slide. I wanted to, in light of the risk of hospitalization that Alan covered, I wanted to talk about a couple of things, a couple of programs to help us avoid hospitalizations for patients with dementia or patients, older adults if possible. One that is not widespread in the U.S., but is an outstanding program to consider is the Hospital at Home programs. There's a wonderful website on the Hospital at Home program, and basically it's a formalized program. They do have a pilot, a successful program at Johns Hopkins, and it's actually used for a fair amount of the admissions in like Victoria, Australia. But they basically bring patients come to the ER. If they meet the criteria for having hospital at home, perhaps it may be like a pneumonia or another type of infection, they will have the physician assess them. They'll go home and they'll receive daily visits, increased nursing care, and they'll be able to have their hospital stay at home. They'll bring all the echoes, the x-rays, and everything to the home. And they've shown very outstanding outcomes for patient safety and satisfaction, as well as reducing costs. Next slide. Another important thing that needs to be discussed with many patients that are experiencing more end-of-life issues, very frail individuals, we need to discuss with them if they've got a comfort goal to not go to the hospital. It's part of a lot of the advanced directives, for example, the PULST and the MOLST and other state advanced directive forms may have a do not hospitalize order on their state advanced directive forms. It's extremely helpful for those in like nursing home settings or patients with hospice, where if you have excellent support in place, it may be best to make sure that there is an order to not hospitalize and to try to manage things at home. If there's severe symptoms like a fall and a broken hip or acute abdominal pain, of course these can be overturned, but in general these try to keep patients in their setting and not moving them to the hospital. Next slide. But for patients who need to go to the hospital, I just wanted to go through a few programs which are very helpful to older adults in general and especially to patients with dementia. Next slide. The first is dementia-friendly hospitals. This was a program that's created by the Alzheimer's Association. It's mainly, it's an outstanding program that offers very practical dementia-specific training to hospital personnel, and it's really focused to go to all the hospital personnel so that they could recognize dementia, understand dementia better, and then communicate with patients that have cognitive impairment more effectively. So it really gives a lot of communication training. This is a free program that the Alzheimer's Association has available to hospitals, and it really is an outstanding program that could be implemented. The local chapters will help with getting started, and there's modules, slides, videos, and doing the training. So it's really worth considering for hospitals to gain this dementia-friendly hospital program. Next slide. Another wonderful model that has been in place for many years and is used at a fair number of hospitals is acute care for the elderly units, or ACE units. The focus of the ACE unit is on trying to maintain function and prevent those iatrogenic problems that happen in the hospital. And so the idea is that there's a stronger interdisciplinary team. Pharmacy reviews the medications every day with the medical director and with the nurses. The nurses go through the care plan, and a lot of the care is driven by nursing protocols and nurse-driven care. More work with physical therapy and occupational therapy, more focus on trying to really prevent those problems. And there's been multiple trials that have been published on ACE units, and the idea is that basically everyone does not have to lose function when they come in the hospital, that by using ACE units we can keep people at their same functional level, decrease cost, and decrease lengths of stay in some of the studies. And so these are really extremely important for patients with dementia, that because of that, because there is a focus on cognitive function and evaluating daily how the patient is doing with their thinking, and all ACE units address the issue of prevention of delirium and also how to manage confused patients in a restraint-free environment is another key issue. St. Louis University published a nice article in their delirium room where they had a restraint-free program to help keep patients with delirium or acute confusional states safe, and so that was also a very nice example of something that was done inside an ACE unit. Next slide. Another wonderful program that is fairly widespread is the Hospital Elder Life Program. This is a program designed solely to prevent delirium and improve outcomes in older adults. Dr. Inoue developed this and published a nice article on this in 1999 in New England Journal, and there's been multiple other articles published. But basically the hospitals register and train to become official help sites, and it's a volunteer-delivered interventions to, and these, just really improving the high-touch care that we give patients, helping them with eating and drinking, helping them get out of bed, making sure they have glasses and hearing aids, and all these types of interventions help reduce the incidence of delirium by 40% in her study that was published. It does require a very significant hospital commitment, and it's more of a unit-based program, so it may spread unit by unit across the hospital, but these have been very successful. And then the last program that I wanted to touch on, next slide, is geriatric emergency rooms. Geriatric emergency rooms have gained popularity, and you'll see some more in terms of advertising and marketing, and so it was outstanding that in 2013 the American College of Emergency Physicians and American Geriatric Society and other societies published guidelines for what should be in a geriatric emergency room, and it's really an important issue because the ER is right there at the crossroads between inpatient and outpatient care, and thinking of the ER as your front porch to your house, we would really prefer to keep our older adults to have a nice visit on the front porch and then help them go home instead of having to bring them into the hospital. But in doing that, it requires a lot of education and a lot of work to have an ER that is more appropriate for older adults, because the ERs, they were designed to be rapid triage centers, and so trying to help them have a different focus it requires a lot of training. The medical director needs to have substantial training. There needs to be geriatrics consultations available, discharge protocols that are focused on communication to providers. The geriatric emergency rooms need to monitor quality measures like their use of urinary catheters, restraints, how many patients they're admitting, and they have to have equipment, environmental changes to support older adults, like having the hearing amplifiers, having better beds that are better for older patients that may have more risk of pressure ulcers and things like that. Next slide. But these are some of the key issues that I really wanted to discuss. In addition, is just for any hospital, the key quality issues for the care of geriatrics patients and older patients in general is just this issue of identification and involvement of caregivers. This is so critical, that both the electronic medical record needs to have a clear place to designate who is the primary caregiver, and who helps makes decisions, and those are critical issues to have documented in the electronic medical record, also on the chart and in the room, so that's a very important issue. We've touched on the importance of increasing mobility, not having it as an automatic to place urinary catheters, and mobility really should be a vital sign. For example, at Beth Israel Deaconess Units Medical Center in Boston. Has the patient been out of bed, and have they moved? Is one is on their flow sheet, and they're charting for the nurses. And then, of course, you know, working with the interdisciplinary team to increase mobility is very important. There's there's some wonderful resources through the Hartford Institute for Geriatric Nursing, the NICHE program, Nurses Improving Care for Hospitalized Elders. This program is also available on the internet. Hospitals can register and become niche hospitals. And there's a wonderful program called Geriatric Resource Nurses that's part of that, that develops expertise in nurses for care of geriatrics patients and those with dementia. And so these are outstanding programs. Next slide. Another is just on the issue that hospitals need to be able to recognize delirium, screen for delirium. They really need to look for delirium, because delirium, I've got the picture of the canary in the coal mine. Delirium is really like your canary in the coal mine. It's a sign of serious illness, especially in patients with dementia. It may be their first sign of illness. And so hospitals need to be prepared and ready to address that issue. Next slide. And along the lines of delirium prevention, the hospitals really need to have hearing amplifiers and glasses available for their patients to use. And then important to have pharmacy efforts to limit inappropriate medications, to monitor and try to reduce the use of high-risk medications in older adults. And the Beers criteria, which is available on the American Geriatrics website, gives a clear listing of medications that may be inappropriate for older adults. And then, of course, involving caregivers and increasing the day-night cycle awareness. Next slide. And then lastly, the transitions of care, which Karen and Alan are going to talk about more in depth. It's really important for patients with cognitive impairment that their hospital has a very strong program to improve communication with care providers at the next facility or their primary care. We really need to improve that communication. One of those programs that I wanted to mention is Interact, Interventions to Reduce Acute Care Transfers, which is a formal communication plan between hospitals and nursing homes, which have shown very good outcomes. So I think that this slide then is a nice introduction for our next speaker, Dr. Karen Rose, and she's going to talk about empowering families and caregivers in transitions of care.
Thank you. It's a pleasure to be on the webinar this afternoon. I'm going to start with the next slide and just dive right into the important role of family caregivers in care of persons with Alzheimer's disease and related dementias, particularly when it comes to transitions of care. There are approximately 15 million caregivers in the United States right now providing care to persons with Alzheimer's disease, and they provide care, billions of dollars of unpaid care. So really, to think of them as key persons, key members of the care team is essential. They do provide the bulk of care to persons with Alzheimer's disease throughout the course of this disease trajectory. So what I advocate for is to treat family caregivers with respect and to handle with care. They really are quite fragile at times and can be certainly the best advocates for their loved ones with Alzheimer's disease. Next slide. So when we think about family caregivers, let me first say, too, that when I say families, I mean very universally families, certainly blood relatives, friends, life partners, whatever neighbors, whatever family definition seems to fit. I think that they all fall under the same category. They want to be informed, they want to be heard, and they want to be ready for what this disease may bring for them in their caregiving role. So they want to be informed of what they can anticipate, and I think it's important at this point to say that the very first thing is to be active listening and finding out from family caregivers, meeting them where they are. If there's a saying that if you know one family caregiver, you know one family caregiver, because no two situations are the same. Family dynamics, as you can imagine, run the gamut, and so really finding out initially, what do family members want and how do they want to be informed? Family members want to be heard. They have a story to tell. They want to be heard so that they can anticipate what maybe the issues may be for them. What are the unique aspects of their family caregiving situation? So they have a need to be listened to. They have a story to tell that if they're listened to, oftentimes can prevent some hospitalizations and some other key transitions. Families want to be ready. They want to be ready for what the future might hold. And again, I'd say to you that this is a time to really assess what they understand about this disease and what they understand about what the future may hold for them. People need to know that this is a progressive degenerative disease, and so care needs will change over time. And so whatever you can do to help them prepare for the future is what they want. And then lastly, they want to know what supportive services are available to them and how to access them. And we'll talk a little bit more about that in a moment. Next slide, please. So in terms of keeping family members informed, they want to know what the plan is for discharge. And I know that to the extent that families want to know tomorrow at 10 a.m., then that's not always a reasonable expectation. They do need to know a bit in advance of when the likely discharge would be for their loved one from hospital to wherever they're going, where their loved one be discharged to, and under what circumstances. Are they going someplace for a short stay for 30 days? Are they going someplace, what you believe, long-term? Is the place from which they came no longer an option? Home or long-term care, whatever that is, assisted living. They need to know under what circumstances this discharge is taking place. I think, too, at this point, an honest communication about the care recipient needs. Family members, it can be a very difficult and a very trying time to hear that maybe remaining in their home environment isn't best, given the resources that families may or may not have, that it may be time to consider another setting of care. And people need to know this. Certainly sensitivity to the unique needs of families. These discussions are critical and complex. Families have varying financial resources. They have religious needs that they want to make sure are attended to. They have complicated family dynamics. So again, if you know one family caregiver, you know one family caregiver. Next slide, please. How to hear families. First to hear them, you need to talk to them, to ask them questions. And certainly very important to this is, what do they want? What are their wishes? What do they think are their best options? Are there supportive services that they believe will help, or are there supportive services that they're not going to use, so don't even go there with them? It's important, too, to summarize the discussions at the end of all of the conversations and provide family members some written information as well, and then also documentation, good documentation in the electronic medical record or whatever medical record is used, so that all providers know, because family members, as we all are notorious for, when there's a parade of care providers, we think of questions that we wish we would have asked someone, but they've come and gone, and so now we're going to ask the next person who walks through the door. So good communication, certainly orally and in the medical record, is key. And certainly a shout out, I want to enlist the assistance from social workers and other supportive staff. They're masters at talking with people, at negotiating, at listening, and so I think it's imperative that you use all of the help that's available to you. Next slide, please. How to help families be ready. So communicate early and often, in person and in writing, as I just spoke to. Many times family members, if they're present at the hospital, at the time of hospitalization, when they get home in the evening or whenever they communicate with others in their family system, they often are the person who does have to communicate to others in the family system. So however you can help them understand what is going on so that they can communicate accurately to other support services in their circle of friends and family is really important. Helping family members think about what-if situations. So, for example, what if they themselves, if they're the sole care provider for their loved one with Alzheimer's disease, what about if they have their own medical needs? How are they going to address those? What if they have themselves some impending hospitalization? How are they going to make arrangements for that? Do they have travel arrangements that they need to change? What are some of the specifics so that they know that they need to be thinking about what if happens? We encourage family members to receive some help to organize a patient file to take with them to all appointments. current list of medications, chronic medical conditions, et cetera, et cetera. So I think it's really important that family members just have a go-to, whatever bag that they pick up and take with them, and that they keep an ongoing kind of filing system, if you will, so that they can manage the interactions that they're having between care providers. Additionally, I think it's important for family members in the phase of helping them be ready is to always have a bag packed, if you will, one for themselves and one for their loved one with dementia. If a hospitalization is needed quickly, then they're ready to go. So again, for the loved one with dementia, it would be, you know, their medications, you know, whatever kind of comfort, or, you know, their own personalized clothing, night clothing, anything of that nature, if they have an additional pair of glasses or anything that might help them be calm and comfortable if they need to transition. And similarly then for the caregiver, to have an overnight bag packed, just so that they're ready in case. I think it's important, too, to discuss realistic expectations about the roles of family members in an atmosphere that promotes guilt-free discussions. Many family members enter into this role of caregiving, some by choice, others not so much by choice. And so they need to know that it's okay if the demands that they're being asked, the care that they're being asked to provide, if they can't reasonably provide that, or they don't want to, or don't have the resources, or whatever that is, that it's okay to say that they won't be judged. That's a hard conversation to have, but a necessary one. Next slide, please. Additionally, how, in terms of helping family members be ready, I think it's important to provide families with a sense of best practices for visiting a provider. So if they can at all enlist the assistance of another person to go along with them when they accompany their loved one with Alzheimer's disease to a care provider appointment, that would be really helpful. 2 eyes and ears are better than 1. Ask them to write down their questions ahead of time. If they have any questions about changes they've seen, questions they might have about medication management, anything at all that's going on that's changed for them and that they're not sure quite how to handle, they need to write down those questions in advance to be sure that their questions get answered. And then I also ask family members to think through the actual day of the visit and what else do they need to have ready for them just to travel to their care provider. Again, as we've heard, in the ideal world, care providers come to them in their home environment. That's not always the case. And so what do family members need to think through just to get the person in transit to the care provider? Next slide. What if situations? Some of this we've already spoken about earlier, but I think it's important to reinforce this with family members. What if their loved one does become confused, has delirium? What are their options? What do they do? Who do they call? The same with falls. What if their family member falls? Is this an automatic trip to the emergency department or not? They need to know that. What about incontinence? As we know that oftentimes as this disease progresses, persons can become incontinent. What do they do then? Is the answer to make a physician's appointment? Is the answer to put an undergarment on them? Is the answer to check with their pharmacist about are any of the medications may be causing this? What are their options and how do they approach this? So just some common things, commonly occurring scenarios, so that family members have a sense of what their game plan might be, which again may very well then avoid an unintended hospitalization. Next slide, please. So critical for family members is linking them to community resources. All too often families feel alone. We know that over and over again from the literature that family members feel like they're suddenly become disconnected with support services, people who've always been there for them, maybe their church, maybe other family members, neighbors, and often at times it's because these other support persons are uneasy. They don't know what to say. They're not sure how to interact with the loved one, and so they avoid. And this really makes family caregivers feel very stigmatized. And so to the extent that we can continue to embrace caregivers and certainly persons with Alzheimer's disease and encourage them to be socially connected. That goes a long way. So through community resources such as area agencies on aging, including Meals on Wheels, this can be a lifesaver for many families. The Alzheimer's Association, there is a helpline that's staffed 24/7. So in the middle of the night, if a family member has a question or a concern or just needs to vent, there's someone there, someone who's trained and available through the local Alzheimer's Association, through the National Alzheimer's Association. Family members need to know that there are respite services available. Some can be accessed in-home and others are facility-based. But to know that these are options, many are very good options, and to help them think through when and how they might access them. Many volunteer services prevail, churches, other organizations, and even locally where I am in Virginia, there's a university who provides some in-home respite care, companion care. And so you may be really surprised about the kinds of services that people can access that may get them through a tough period of time. Even a 2-hour respite on a Wednesday afternoon may be enough of a break for a family member to keep going. Adult daycare settings, if this is appropriate for the individual, may be a good option. And then other web-based navigation services and sources of information. Increasingly, we know that family caregivers, about 1 in 4 are millennials. They're very comfortable with the accessing the internet for information and resources, and so we need to be sure that we connect them in that way as well. Next slide, please. Special needs when loved ones are transferring from and back to an assisted living or nursing home setting. Certainly communicating with the receiving setting is critical to ensure the best transition possible. Certainly communicating any changes in medications, because that is the #1 issue that comes to the forefront, that family members are confused about what the medication adjustments were. Care facilities may be confused if documentation isn't very tight, and so really being very explicit about the medication changes is something that certainly helps smooth a transition back to an assisted living or nursing home setting. And then again, providing documentation if there have been any advanced directive changes, any other special needs of the recipient and family that may have come about as a result of the hospitalization certainly need to be communicated. Next slide, please. For those persons who are transferring home with home health care providers, family members need to understand what home health is and what it is not. Many persons are under the premise that home health services are coming in and they're going to take care of everything. They're going to be there for 8 hours a day and bathe their loved one and feed their loved one and take care of all kinds of activities of daily living, and that may or may not be the case. Family members need to know what types of services they can expect, for how long, is this time dependent, likely so, what is that time period, what is the family's role in arranging this, and do they have a choice of providers? They do have a choice of providers, and they do need to know what those choices are and how to access those choices. Next slide. So special needs, certainly for transferring from any setting, I can't say it enough, the clear communication and documentation about any and all changes. Medications we know is the big one, advanced directives, wound care, feeding and toileting, making sure that family members understand what changes they need to implement from what they were accustomed to. It certainly does help them plan and be prepared and hopefully not be able to prevent any additional hospitalization. Next slide. So caring for the caregiver, I know this is an often overused phrase, but I think it's critically important. It's everyone's job to assess how the caregiver is coping and managing with their own care. Time and time again, we know that family caregivers oftentimes have ill health effects for themselves, but because of the tireless care that they provide their loved one. So making sure that family members themselves who are care providers are taking care of themselves. That they need to know that it's okay to ask for help and that they need to ask for help, that they need to be encouraged to ask for help. And oftentimes reinforcing the notion that over time it may be that the best place to provide care for their loved one may not be in their home setting. They may not have the capability to do that. So helping them understand that and helping them think through that so that they too can have some of the critical conversations that they need to have. Next slide. Helping family members adjusting to the new normal. And I put that in quotations because invariably, and as Dr. Stevens said earlier, whenever a person is discharged out of a hospital to another care setting or back home, oftentimes they have had some functional decline as a result of that hospitalization. And so helping the family members understand that their loved one may not be the same quite, and may not have the same capabilities that they had prior to the hospitalization. They need to be reminded that this is a progressive debilitating disease and that the care needs for their loved one will change over time, and that they will likely need to enlist some other assistance. I say, too, that helping family members embrace palliative versus curative ways of thinking as appropriate to their situation is certainly a good way, is certainly a notion that families need to embrace, and I believe that healthcare providers are doing a better job of that, but I wanted to reinforce that. So these conversations can be difficult but necessary, and they may make or break transitions of care. Now I will hand off to Dr. Alan Stevens.
Thank you, Dr. Rose, and good to be back to talk about the role of care transitions, and I'm going to be specifically talking about the care transitions intervention and how we have implemented it in a number of ways here at across our system at Baylor Scott & White Health. I'll be speaking specifically about how we have done it at our hospital here in Temple, Texas called Memorial Hospital. Next slide. The Care Transitions Intervention was created by Dr. Eric Coleman probably some 15, 20 years ago now, and it still remains one of the most cutting-edge ways of reducing 30-day readmissions. It's designed, and the reason that we selected it for our use at our hospital, and what others I think will across the nation speak to, is that it is designed not to provide a specific service to a patient or family members at a time of discharge. It's designed to encourage patients and encourage their family caregivers to learn new skills and to become more active in seeking the information that they need when they move from one care setting to the next. Very often, and what I'll be speaking about today, is when they move, when the transition is from hospital care back to home care. And that's done by an approach that is what we call coaching rather than teaching, and I'll describe that as we go through the presentation. Next slide. So why is this necessary? Why is it important? As I said, this is a strategy of helping individuals, and we're teaching a strategy and coaching people rather than saying this is one specific service here, just do this. Is because there's such diversity in what individuals need when they leave the hospital, and the hospital, or especially our hospital, feels like the patient's care outside of our hospital is just as important as the care that we provide in the hospital, and therefore we need to understand it. We need to understand the patient's life when they're not in our hospitals or clinics, to really understand how to best care for them and to adapt or modify care to address their needs, person-centered care. At a time of transition from a hospital to home, there is a specific need for a transition, what we call a care transitions coach. And this is the concept that Dr. Eric Coleman built the care transitions intervention around, was that when a person is leaving the hospital, an older adult, especially an older adult with multiple chronic conditions, that they should have a brief meeting, a contact with a coach before they leave the hospital to kind of go over some basics, and then have some follow-up support from this care transitions coach, both in an in-home visit and in telephone calls for the 30 days after they leave the hospital. And again, why would that be necessary? It's because, as this slide, I hope, illustrates, the landscape in which a patient returns is complex. And this is just an example of the different organizations, sites of care, potential sources of support that an older adult may encounter upon discharge from a hospital, sorry. But as you can see, once out of a hospital, you may have to go to a clinic. There may have to be something that you have to do with a health plan. You may need to arrange for home care. Almost always, there's a need for pharmacy. And in many communities, there are forms of social support that Dr. Rose just mentioned that could come from the Alzheimer's Association, from Meals on Wheels, or from government organizations like the Area Agency on Aging. So integrating the care plan, the person's plan of care for themselves when they get home, is complex and requires coordination across many entities. This is occurring when a person is still recovering, and that often means things fall through the crack. A patient doesn't have the strength to make it to an appointment at a clinic for a follow-up. They're not motivated to go to the pharmacy and get their medications. So having a person who comes to your home, spends an hour with you, looking at your discharge plans and discussing with you how you plan to spend the next 30 days based upon the fact that you've just gotten out of the hospital, is an incredible service to patients. Next. So the Care Transitions Intervention, developed by Dr. Eric Coleman, who I'm sure many of you know or have heard about, has really been one of the leading thought leaders in this field. And as I said, it's designed to impart skills and confidence, not to provide a specific service and the same service to every person. It is a form of support and skill building at a critical time in the person's life when they're transitioning from the hospital to home. Next slide. So what is the Care Transitions Intervention? It is a coach-driven intervention, which means the individual who approaches the patient in the hospital and establishes a relationship in a very brief interaction, and then moves to the community with the person after the person is discharged from the hospital. Then they go and see them in their home for one home visit, and then conducts 3 telephone calls. So it's really person-driven. In this case, we'll call it coach-driven. And the coach is there to work with the patient, and many times with the families, to ask questions, to seek out information from the family, to get an idea of what's the patient and the family's skill level. You can get a really good idea of what their health literacy is. You get an understanding of how goal-directed they are, and most importantly, you get a really good idea of how prepared is the patient to now self-manage their recovery at a time in which they have just been over-cared for, as we talked about earlier in Dr. And Katie's talk, that now's the time that we really need to make sure they get good services. The intervention itself, so it's driven by a coach. The intervention itself is designed to do two really specific things. One is to set a personal health goal, and that's to get the person and the patient thinking back in terms of, what do I want to achieve during my recovery? What do I really want to get to? From their own personal experience, and it should be something that is personal and meaningful to the patient. And secondly, the coach is then in the home, in the one home visit, to discuss with the patient four areas or four topics that are well known to be associated with a 30-day readmission to the hospital. And I'm actually going to, and of those four pillars, we're going to talk about each one of them in depth. So I'll move on from there to say, and repeat myself again, because I think this is really important. The intervention is very contained. It is a 30-day intervention. And you have face-to-face contact with the patient and family only twice. Once in the hospital, and that's to introduce the concept and to hopefully get the patient to agree to the service. Usually can be done in 10 or 15 minutes. One home visit, which is critical to the success of this intervention. So a coach goes to the patient's home, hopefully within 72 hours after discharge, and then does 3 structured follow-up phone calls within a 30-day period. Next slide. So let me go now into each of the 4 pillars that make up the majority of the content of the focus of the intervention. So the personal health record. There's been a growing amount of attention in media and in healthcare in general about the need for individuals to have their own records of their health and a record of their medications. And even the idea of someone having a list of medications has become really quite common today that we didn't see just even 5 years ago. And so Dr. Coleman and his team created a personal health record that's a key part of the intervention and also serves as a summary of the different aspects of the care transitions intervention, and I'll hopefully be able to demonstrate that for you in the coming slides. What do we do with the personal health record? We use it as a place for the patient to record the health goal. As you remember, that was one of the things that we said was kind of one of the major parts, is to have the patient identify a goal and have the patient write it into the health record themselves. Through the course of that home visit and the coaching that the transition coach does, it leads to a list of medications and often questions for healthcare providers. So this, while doing that part of the medication review, the personal health record provides a structured place to record the medications and questions for the doctor. It has a place to list red flags and action plans related to red flags. So this is basically signs and symptoms of when the patient feels like their health is declining, and what are they going to do about it when it does. We already said questions for the primary health specialist, and those points there are the major focus of the home visit. There's some additional space in the health record, the personal health record for a medical history. We encourage patients to do that. We encourage them to put this and use this as a place to have all of their contact information. But that's generally done by the patient and the family either prior to or after the home visit. The home visit is really focused on developing skills that are important in the patient's recovery. Next slide. Medication review, the second of the 4 pillars. We specifically call this medication review because it's, to make a distinction that it's not medication reconciliation. Rather, it's a process that takes into account 3 unique pieces of information, or you could say 3 data points, that are all important to understanding how a person is taking their medication, how do they understand their medication, and what may be changing with the medication based upon the hospitalization. So in a medication review, very simple, you ask the patient to bring all of their medications out, and usually that's to a kitchen table. Through that process, you collect the patient collects the information, the bottles of medication, both prescribed and over the counter, and the coach sits with the patient and says, so pick up, start with one of your medications, any one you want, pick it up and tell me about it. Tell me how you take that. Just in that kind of very open-ended, non-judgmental way of trying to get a self-report from the patient of how the medication is being taken. That's followed by then, if the patient doesn't do it automatically, to have the patient actually read the instructions on the medication bottle. And then the third data point would come from the discharge instructions from the hospital to see how that medication, or if that medication, is represented on the hospital discharge. So now we have three pieces of information: how the patient's taking it, how it was prescribed, and how it's reflected on the medication section of the discharge summary. That, along with the coach, then integrates those 3 pieces of information to see and make an assessment of, does all of this align? Does it seem to be, all as we would expect? Or are there some issues? And issues are what we call medication discrepancies. And a discrepancy is basically when any one of these 3 things or other information you've gotten don't align, and bells go off of, uh-oh, we got a problem. And then the coach discusses that discrepancy with the patient and encourages the patient to come up with a solution that would address the discrepancy. Most of the time that means getting some additional information from a formal health care provider. The coach, who is often not a clinician, is never there to give medical information. The coach never assumes that any one of these 3 pieces of data that they're collecting is the gold standard, that any one is better than another. They're not clinically trained to do so. And in fact, we don't want them to play that role. We want the patient to be empowered to learn from this structured experience and to come up with a solution. Next slide. Red flags. I'm sorry, I've got to speed up here. I didn't realize I was taking this long. Red flags are basically signs and symptoms, often related to what may have led to the hospitalization, and there's a place in the personal health record to record them. Just one note here: the coaches work to make sure that these are written and worded in a way that are familiar and comfortable to the patient. So if the patient says, you know, I always know something's going on when I can't put on my slippers in the morning, that's a red flag. You know, it doesn't need to be in medical language. In fact, it should be in the exact words of the patient, and it should be the patient writing it in the PHR. Next slide. Follow-up appointments after a hospitalization, hopefully within a week, are really critical to avoiding a 30-day readmission. And that's for a number of reasons that we won't go into, but quickly let me say that the care transitions intervention is built on that fundamental assumption. Therefore, the work of the home visit is designed to prepare the patient to get the most out of that next, out of that follow-up visit. So all of the interactions are gauged towards identifying where there may be problems, activating the patient to engage in a discussion with a healthcare provider about that information. The personal health record is the place to record it all, and then of course we encourage them, the patient, to take the personal health record to the appointment. And there are many teaching techniques that we use around that to ensure that the patient has the confidence and the motivation to actually go to that follow-up appointment. Next slide. So here's a case study of what a care transitions intervention looked like in our group. Next slide. Let me just very quickly say, so this was a female patient. She was discharged from the hospital after being in the hospital for sepsis due to a UTI. We go to the home visit, and basically her medications are a wreck. There are 11 discrepancies. We call back a few days later, understand that the patient has been to has seen a primary care doc, expressed some concerns, and they seem to be moving to a reconciliation of the medications. And then on the second phone call, in talking with the coach talking with the patient, we realize, or the patient reveals, that she's having some red flags, that some of these same signs and symptoms that that she associated with the UTI that put her in the hospital, she sees them coming back, and she's at a loss of what to do. Next slide. And so that's a real case from one of our programs, and from our electronic medical record and some dictated notes, we can go in and see that after that home visit, she did indeed make a primary care visit, and we can see from the notes dictated by the physician that the issues of medications did come up. It was noted that there were a number of discrepancies based upon her stay in the hospital, and that the physician had worked to reconcile that issue. Next slide. This comes out of a note on the day after the second phone call, where, again, the patient has been seen. The doctor has done an assessment and realizes that the UTI is very complex, getting her on medication and making a referral to urology. I show these to indicate that patients really do benefit from this intervention. They get activated, they have a plan of action to move forward, and we see it work day after day. Next slide. So what's the role of the family caregiver? Basically, everything I've just been talking about that was an intervention designed for older adults with multiple chronic illness, in many, many, many cases, a family caregiver is through there for the whole period of time for care transitions in general. In fact, we see that if you have a family caregiver involved, a patient is much more likely to engage in these kind of post-acute care activities. So there's a lot of very often this is a husband and wife, very much a team around the health care. Next slide. So to more formalize the role of the family caregiver, Dr. Coleman has recently done work to make some specific changes in the way that the core elements of CTI have not changed, but some of the implementation strategies that you use in working and delivering the intervention have been modified to more formally include the family caregiver. Now, again, in many cases, the family caregiver is not formally involved, but this gives them a formal role, and it gives them an opportunity to set a goal for themselves. So to tie back to Dr. Rose's point, often that's doing some kind of self-care for themselves, and some initial testing of the model shows some benefit of having the family caregiver role formalized. Next slide. For more information about the care transitions intervention, I suggest going to this site. This is the main website for Dr. Coleman's intervention. You can learn more about training. There's tools. There's a lot of information there. So if you think this intervention fits for your setting, please go and seek out information from this website. Thank you.
Thank you, Alan and Karen and Katie, for your presentations. That was a really great conference that we had today, and I just want to go through a few points before we get to our Q&A. Carol, did you want to just step in before we start with the Q&A too?
No, I'm okay. I want to take the last 15 minutes for Q&A because I see we have a lot in line, but thank you, Jesse. Okay. Let's just get to the questions.
Okay, great. So just before we go through some of the questions that we've received from the audience, just regarding CME and CE credit, the post-test and the evaluation will appear in a new browser window once the event actually ends, so after the Q&A. If you do want CME or CE credit, please be sure to complete all the questions in the post-test. You must receive 80% on the post-test to qualify for credit, and all of the questions on the evaluation before clicking submit at the end. If you're not seeking credit, we do encourage you to also complete the evaluation when it appears on your screen. Finally, a recording of the event as well as the slides will be available shortly at resourcesforintegratedcare.com. And if you have any questions at this time for our speakers, please submit them using the Q&A function on the right-hand side of your screen. So to kick things off, I have a few questions that have come in here. I think this first one is directed to you, Katie. The question here is saying that they're concerned that a transition from a hospital to assisted living or nursing home for a patient with dementia and or delirium may actually confuse the patient. Is it better for the patient to be home in familiar surroundings if possible?
Yes, always for a patient with dementia, it's better to be at home for the issue of confusion with the surroundings and trying to acclimate to their normal routine. However, sometimes that's just not feasible. A lot of patients leave the hospital with significant deconditioning, or they need some more complicated wound care or IV antibiotics or something that requires them to go to like a skilled nursing facility for a subacute rehabilitation stay or something like that. And so if it's not feasible to go home, then it is really important to have that communication with the facilities and with the other physicians. But either way, no matter where the transfer is going to, it's just so important that we get all the information accessible to the caregivers, because the patient who's had delirium or the patient who has dementia, you know, they really need a lot of support and assistance, and so that all the critical information about medications, follow-ups, other studies that need to be done, all those things, we have to find a way to communicate that to the caregivers so that they can be equipped and ready to give that information and to have it in hand. I try to encourage people to use that information, and also make sure that even if they go to a facility, that the facility has the same information that they have, or to ask to look at the medications at the facility, to look at the medications at the assisted living, because sometimes things fall through, and so either the caregiver themselves or asking a home health nurse or somebody else to recheck those medications at the assisted living or at home or at the facility is really helpful to try to double check what has happened in the transition.
Thank you, Katie. I have another question here. I think, Karen, this could be directed to you if you'd like to start off. Most patients I see in home health do not have caregivers who are really involved or buy into this model. They seem to want the patient with Alzheimer's disease to go to a day program instead. How do you feel about that?
It's a great question. So again, I think I'd say not every caregiver, everyone's circumstances are certainly different, and I do believe too and understand that many of our family caregivers are still actively working, full-time. Many have had to cut back to part-time or no time because of their caregiving responsibilities, and they have certainly real financial risks that they incur as a result of that, or consequences, if you will. So I think that on the one hand, certainly, adult daycare centers are great for socialization. They're great for routine. They're great for certainly providing stimulation, which is really important for persons with Alzheimer's disease, dementia. And they also can be a source of respite, if you will, for the family member who's their care provider. On the other hand, home health certainly has advantages depending on what the needs are. Certainly, home health care providers aren't typically in the game of don't get reimbursed so much for, cognitive stimulation, socialization, those kinds of things. It's oftentimes very, as you know, medically based and task-oriented. So it's kind of comparing apples and oranges, if you will, in my mind. Both certainly home health and adult daycare serve a purpose and fill a void. It's just making sure that caregivers are fully aware of what those two services do and don't provide, and certainly the cost associated with them. I hope that at least initially answered some of the questions.
Yes, thank you. Okay, Alan Stevens, I think this one might be a good one for you. How does a skilled nursing facility know if the hospital is doing all of these great educational things and follow-up calls? Are those actions included in the record?
I'm sorry, can you say the very first part of the question?
Oh, sure, sorry. How does a skilled nursing facility know if the hospital is doing all of these great educational things?
Generally, it's going to be communication between the discharge planning team and then the admitting team or the social work team at the skilled unit. Most of the things I talked about are done for individuals going home, where patients are activated and and caregivers are activated to be more self-directed in their care. So that's not a good answer to the question because we often don't do these kinds of care for people going to nursing homes or skilled nursing homes. The program that is better for that is the Interact program. And that is one that Katie talked about in terms of where the hospital and the skilled nursing unit or the nursing home work and coordinate transfers between their facilities, and that seems to benefit the patient very much.
Hi, this is Katie. Dr. Agarwal, I might add in that it may be of value for skilled nursing facilities and nursing homes to actually ask their local hospitals to help them understand and to list what are the programs that they have for their elderly patients, because I think as there's such a changing environment for nursing homes to be responsible for the care of their patients and readmission rates and you know, and thinking about what's going to happen to their patient when they go, if they have to go to the hospital. I think it's a great question for the nursing homes to address to the hospitals, you know, try to understand what are the programs that hospitals have to better care for their patients, so that nursing homes may decide that Hospital A is going to possibly give better care to their elderly patients than Hospital B, which is less focused on geriatrics and the care of the older patients. So it may be that the nursing homes want to investigate and talk to the hospitals and you know, interview them for how are they best equipped to care for their patients.
Great, thank you, Alan and Katie. We have time for one final question here, and I think, Katie, you might be the best to start this one off, so feel free to pass it on to one of the other speakers. How is a hospital at home different than home health care?
So the hospital at home programs are truly hospital level of care at home. And there's only very few, probably a handful of these in the United States. One that's been published is Johns Hopkins, and I think I had given the website earlier. It's in the slides for the hospital at home program, but it's truly a formal hospital level of care at home, where the person comes to the ER, a plan of care is given, the physicians who are affiliated with hospital at home, the physicians come to the home maybe even twice a day for the first few days. While they might be sicker, they have greatly increased nursing care. They'll even have tests coming to the home, x-rays, echocardiograms, EKGs. They manage to bring all of this acute level care into the home. And of course, home health does a lot of that too, with continued IV antibiotics and visiting the patients. But typically, home health would not come to the home more than once a day, and typically, sometimes more. But the hospital at home program may have people there, should have people there multiple times a day to emulate the hospital level of care, but just in the home setting, whereas home health is more designed to be the step down to do more post-acute care and to help patients in their transition to home, but not really provide that same acute level of care.
Great, thank you. Karen or Alan, was there anything you wanted to add to that before we round up this webinar today?
No, I don't think so.
No.
Okay.
Right.
Great. Well, thank you all again for participating in the webinar today. This was very educational, and we hope that all the participants got a lot out of this. We have up on our screen here now information about our next webinar that will be on August 4th, again at noon Eastern. The topic will be understanding and responding to behavioral symptoms among individuals with Alzheimer's disease and related dementias. And for more information on that and other resources, please visit www.resourcesforintegratedcare.com to register. As a final reminder, if you're seeking CME or CE credit, the post-test and evaluation questions will appear in a new window just as we close the event on the WebEx. If you have any questions or comments, please email ric@lewin.com. That's Lewin, lewin.com. All the slides for today's presentation and a recording and a transcript will be available as well at the Resources for Integrated Care website shortly. Thank you again for your participation and have a wonderful afternoon.